Hello everyone, welcome back to my YouTube channel. My name is Dr. Gohar Hamid, and our today's topic of discussion is heme synthesis and lead poisoning. We will also cover acute intermittent porphyria and porphyria cutanea tarda in our upcoming lectures, but for now, I would highly recommend you to memorize heme synthesis first. Once you know the normal, how the heme is synthesized and where the heme is synthesized and what enzymes are involved in heme synthesis, then it would make a lot easier for you to understand the abnormality, to understand the diseases and what enzymes are involved and at what level the enzymes are involved or inhibited in certain diseases. Okay, so for heme synthesis, first you should know that part of the heme synthesis occurs in mitochondria and part of the synthesis happens in cytoplasm. Okay, what two things we need, what two ingredients we need to synthesize heme? So, first we need succinyl CoA plus glycine. When these two combine with the help of enzyme aminolevulinic acid synthase, which is the rate limiting enzyme, again, you should know this aminolevulinic acid synthase is the rate limiting enzyme because in the next step you will get to know about aminolevulinic acid dehydratase. So dehydratase is a different enzyme and synthase is a different enzyme, and the rate limiting enzyme is ALA synthase. Okay, and with cofactor vitamin B6, we when succinyl CoA combined with glycine with the help of ALA synthase and vitamin B6, it forms aminolevulinic acid. Okay, so this is the rate limiting step. Succinyl CoA plus glycine, which forms aminolevulinic acid. This is the rate limiting step of heme synthesis. Then, this aminolevulinic acid, with the help of an enzyme ALA dehydratase, it leads to the formation of porphobilinogen. Okay, porphobilinogen that comes into the cytoplasm, and then with the help of an enzyme porphobilinogen deaminase, it becomes hydroxymethylbilane. Okay, and then hydroxymethylbilane converts into uroporphyrinogen 3, and then uroporphyrinogen 3 converts into coproporphyrinogen 3 with the help of an enzyme uroporphyrinogen decarboxylase. Then this coproporphyrinogen 3 again enters into the mitochondrium and becomes protoporphyrin, and then this protoporphyrin when combines with the iron it becomes heme. Okay, then heme combines with the globin to become hemoglobin. Okay, so yeah, this is all you have to memorize. Okay, I cannot help with that, you have to memorize it at any cost. So the important stuff here which you should know, that this rate limiting step, this enzyme ALA synthase, okay, this enzyme is defective or inhibited in sideroblastic anemia. Okay, then the second enzyme ALA dehydratase is defective in lead poisoning. Not only this enzyme, but also ferrochelatase, the enzyme that is helping protoporphyrin to combine with iron to become heme. This enzyme is also defective in lead poisoning. So there are two enzymes, ALA dehydratase and the ferrochelatase. These both enzymes are affected in lead poisoning. Okay. The third enzyme is porphobilinogen deaminase, which is converting porphobilinogen to hydroxymethylbilane. So this enzyme is affected in acute intermittent porphyria. Okay, why it is important, why this whole cycle is very important for you to memorize, because take for an example acute intermittent porphyria. We will learn about it. Acute intermittent porphyria, the enzyme that is defective is porphobilinogen deaminase. When this enzyme doesn't work, porphobilinogen cannot be converted into hydroxymethylbilane. So in the serum we'll see elevated level of porphobilinogen. So it is very important for you to understand that which enzyme is affected and which substance, which molecule is then elevated in our circulation. Okay, and then this enzyme, again very important, uroporphyrinogen decarboxylase, which is converting uroporphyrinogen 3 to coproporphyrinogen 3, is defective in porphyria cutanea tarda. So you will see elevated level of uroporphyrinogen 3. Okay, So this is very, very important. Heme synthesis is very important. Okay. Now we will talk about lead poisoning. Okay. So the two enzymes that are inhibited in lead poisoning are a first is ALA dehydratase, not ALA synthase. The ALA dehydratase is inhibited and ferrochelatase is inhibited. So when this enzyme ALA-D in lead poisoning, with this enzyme is inhibited, when this enzyme is defective, when this enzyme is not functioning, so aminolevulinic acid cannot be converted into porphoblinogen. So we will see elevated level of aminolevulinic acid ALA. Okay. Then this enzyme ferrochelatase is also inhibited in lead poisoning. So protoporphyrin cannot be converted into heme. So we will also see elevated level of protoporphyrin. Here I want to clear one thing, that porphoblinogen is different from protoporphyrin, because when I was studying for step 1 and step 2, these things, these small things, they were really difficult for me because I got confused with the porphoblinogen and protoporphyrin. So these two are different. Okay. ALA synthase and ALA dehydratase, they are different. Okay. So um, when ALA dehydratase and ferrochelatase, these both enzymes are defective in heme synthesis in lead poisoning, so we will see elevated level of aminolevulinic acid and protoporphyrin. Okay, look at here. So affected enzymes in lead poisoning are ferrochelatase and ALA dehydratase. So what substrate will be accumulated? Protoporphyrin and ALA in the blood. There will be elevated level of protoporphyrin and ALA. Okay, elevated level of protoporphyrin and ALA in the blood. Okay, now um, this lead poisoning not only inhibits ferrochelatase and ALA dehydratase, it also inhibits ribosomal RNA degradation. Okay, we have three types of RNA: the ribosomal RNA, messenger RNA, and the transfer RNA. As far as I remember, yeah. So, so this lead poisoning also inhibits ribosomal RNA degradation, and that leads to, in the RBCs we see retain aggregates of ribosomal RNA, and that we'll see as basophilic stippling. Look at this image A, very important image for you, for your exam purpose. It's very important. Look at these purple dots. Okay, this is basophilic stippling. And why we are seeing basophilic stippling in lead poisoning? Because it is very high yield finding in lead poisoning, which is basophilic stippling. And this purple dots, these are basophilic stippling. And now the question arises, why we are seeing these basophilic stippling in lead poisoning? So because in lead, when the lead poisoning happens, it inhibits ribosomal RNA degradation. So in RBCs, we see the RBCs has RNA, ribosomal RNA, messenger, and transfer RNA. So this ribosomal RNA cannot get degraded, and so we'll see the aggregates of ribosomal RNA as basophilic stippling. Okay, so we are seeing three things. The first is accumulated protoporphyrin. We are seeing elevated aminolevulinic acid. And third, very important, we are seeing basophilic stippling in RBCs. Okay. Now, what are the risk factors for lead poisoning? Lead poisoning can happen in children and can also occur in adults, but the risk factors are different. In children, the most common risk factor is eating lead paint. So in the question scenarios, they give you like um, a 5 or 6 year old boy, he visited his grandma's house. That house was built before 1978. That is an old house. So they give you certain this kind of description, and when they give you this kind of description, you should know that they are giving you um, that the child must have exposed to the lead paint, that child must have eaten that lead paint, because the old houses, has this, they are chipped with the paints. they are of lead, they are lead paint, and mostly the houses that are built before 1978, they usually have the lead paint. Okay, so this is the number one risk factor in children who can expose to the lead. In adults, um, those who are working in the industries, and they are industries, and they are working in a the factories that make batteries, and so they got um, inhalation of that material, that lead, during the industrial work. That is the risk factor for adults. Okay, now what are the symptoms of lead poisoning? So you should remember that first, and very important. We will see the different kinds of symptoms. We'll see the neuropsychiatric symptoms, we will see the gastrointestinal symptoms, and we will also see the general symptoms. So in lead poisoning, first we'll see lead, what we call it, lead lines. Okay, the first is lead lines on gingiva and metaphyses of the long bones, of our long bones here. So first we'll see the from the, you can remember it as lead. From L, you can remember that we will see the lead lines on gingiva and the metaphyses of long bones. Second, from E, you should remember that we will see erythrocyte basophilic stippling. Okay, very important. And from E, you should also remember encephalopathy. Okay, because lead, when enters into the brain, can lead to neuropsychiatric symptoms. Okay, and yeah, and we from E, we should remember two things: the erythrocyte basophilic stippling and encephalopathy. And from A, always remember anemia, sideroblastic anemia, and abdominal pain. Okay, we call it lead colic. Okay, so it is very high yield, because in the scenario they give you that that this teenage boy visited the grandma house, and that house was built before 1978. Now he's having neuropsychiatric symptoms and certain kind of anemia, and then they also has an abdominal pain, so these kinds of symptoms. And from D, you should remember wrist and the foot drops. Okay, again, very high yield um, point you should remember for lead poisoning. Okay, now how we diagnose the lead poisoning, what labs? So in the labs we see decreased hemoglobin, because obviously lead poisoning lead to anemia. And we'll see decreased MCV, because lead poisoning leads to microcytic anemia, so the MCV will be low. um, so let's take a step back, and you should know that there are three types of anemia: the microcytic, normocytic, and macrocytic anemia. Okay, so in microcytic anemia, we divide microcytic anemia into two categories. The one is due to defective heme synthesis, and the other is due to defective globin chain synthesis. Okay, so the diseases that comes in the category of defective heme synthesis includes iron deficiency anemia. Okay, the second is lead poisoning, because I have already talked about this heme synthesis. Okay, so um, and the lead poisoning comes in the category of defective heme synthesis. Then third is sideroblastic anemia, and the fourth is anemia of chronic disease. So these all four diseases comes in the category of defective heme synthesis, and these all defective heme synthesis and defective globin chain synthesis, that includes thalassemia. So all defective heme synthesis and defective globin chain synthesis, these all diseases, they are causing microcytic anemia. Okay, um, so in the labs, we see decreased MCV, microcytic kind of an anemia, decreased hemoglobin, and we'll see decreased venous lead level, and we'll also see what we have already talked about: increased protoporphyrin and aminolevulinic acid levels in the blood. Okay, now how we treat? First of all, remove the patient from the exposure, remove them from the lead exposure. Okay, one and very important. Second is we'll do the chelation, and chelation with succimer, EDTA, and dimercaprol. So these are all the treatment options for lead poisoning. Yeah, before we end this lecture, let me show you this image. So that should be which page? I think page number two. Oh, I cannot find it. So, yeah, this is all about lead poisoning. In the next lecture, we will hopefully we'll cover acute intermittent porphyria and porphyria cutanea. Again, very high yield topics for step 1 and step 2. So yeah, thank you so much. If you have any questions, you can ask me in the comment section. Bye.